Good evening, everybody, and welcome to this third movement disorder seminar and the final one in the series of neuromodulation in movement disorders that we will be having today. We had a very exciting participation and lecture series from the first two webinars, which was highly appreciated. This is going to be surgically focused, surgical centric webinar. The beginning will be done by Dr. Petrus Vadia, and then we have a very interesting debate between a neurologist and a neurosurgeon to see whether early DBS is effective or not. So we look forward to hearing lectures in this webinar. As usual, please put on your comments and questions in the chat box, and we will be checking that at frequent interval, and we will take up for discussion after the in between the session and at the end of the session. So first of all, I would like to express my thanks before we formally start the webinar to Intas Pharmaceuticals and Electra Division for their educational grant support for helping the ISSFN to conduct this webinar series. And they have been also helping us with the organizational support as well. The first speaker for today would be Dr. Petrus Vadia. We had heard him about talking about basic DBS programming in the last webinar. Today he is going to take us through advanced deep brain stimulation programming and troubleshooting for various problems that you may encounter after performing deep brain stimulation surgery. I know many surgeons are not doing the programming, but there was a survey which was conducted by Michael Okun's group and another survey conducted by, along with my help across the Asia, which showed that around 35% of the neurosurgeons in Asian continent still program DBS, which is very unusual because in US and Europe, most of the DBS programming is done by neurologists or either the help with the company personnel. So let us hear, and it would be interesting to know because we need to know everything about DBS when we talk that. I will stop my screen share and invite Dr. Petrus Vadia. Dr. Petrus Vadia is a consultant neurologist and a colleague of mine working at Jaslock Hospital. He has a special interest in movement disorder and practices as movement disorder specialist with a vast experience in DBS and botulinum toxin. And this is one of his areas of great interest, programming of deep brain stimulation. Over to you, Petrus.
Thank you very much, Paresh, for the introduction, and I'll take it from where I left out last time. Is the screen visible and am I audible?
Yes, you are audible. Screen is also seen nicely. Yeah.
So last time, just a recap, we discussed out when is the right time to do DBS. In sense, we should do DBS after the lesion effect resolves, but we also discussed that in a setting where the patient is in the hospital, you may choose to do programming right then and there. So that's the first one. Second is stimulation of contacts. We discussed that you stimulate the contacts in a monopolar setting with a fixed frequency, usually 130, fixed pulse width, usually 60, using a constant current. We use rigidity if present for efficacy. We also find the stimulation-induced dyskinesias is a good positive sign, and we assess the side effect threshold for each contact. Once the best contact has been chosen, we gradually increase the amplitude on that contact in case of Parkinson's disease, while in case of dystonia, you'd probably go straight away to a higher stimulation. And in Parkinson's disease, you have to reduce the dopaminergic doses in contact, and you increase up to the threshold of side effects or dyskinesias. What happens in this monopolar setting? About 40 to 50%, or maybe even 60% of the patients, if your lead placement is perfect, would be done, and you probably don't need to deal with them at all. It's the best of the session is for those who are not so easy to satisfy in terms of their control of symptoms. And many people, you may feel satisfied, the patient is not, and that's always the biggest challenge. So if you feel that a particular symptoms are not controlled or their Parkinson's is not doing as well as it should be, check the lead position, check the impedance. We already discussed how to check impedance at the last time. We discussed pulse width and frequency modifications the last time. Lower pulse width will increase the threshold of stimulation. Frequency modulations, high frequency if you're having postural instability, fascination, tremor. Lower frequency if you're dealing with freezing of gait. Sometimes helps, not always. Contact modification is what I'm going to be discussing next. So you can use two adjacent contacts and stimulate them in a monopolar fashion, or you can use one if you're having a lot of side effects due to current spread. You can focus the stimulation by using the best contact as the cathode and the next best contact as the anode. That's a bipolar stimulation. So the cathode being negative and the anode being positive. You can use interleaving, or you can use fractionation of currents, which is available only in the Versailles and the GVR systems, where you can choose 70% of stimulation coming from, say, contact 2 and 30% from contact 3. And of course, the newer thing is directional leads, which are available in Boston and Abbott systems, and I'll be discussing that. So the next thing that another thing that I will touch upon is directional leads. I'll be spending a little bit of time because directional leads are available and we are using them now. Adaptive DBS or closed loop DBS, which is still at a research tool, but the Percept PC is going to be launched with the adaptive function, but the adaptive function will not be switched on until all regulatory approvals come in. And then the concept of computer-based guided programming or motion sensor-based guided programming, which is probably going to make life easier, but whether it will make it easier or not, we have to see as time will tell. So we'll move along to management of contacts. So when you have an issue where you're not stimulating the right contact, you can do what is called as monopolar stimulation, where you stimulate only one contact, or double monopolar, where you're stimulating contacts, say 0 and 1, or you can do bipolar, where you put 0 as negative, 1 as positive. This way you're focusing the current. So bipolar stimulation, you have to increase the amplitude. The amplitude almost doubles. So it's expensive on battery life, but if you're having a very difficult side effect, bipolar is good. But many times bipolar doesn't really help control all the bradykinesia or the akinesia well. If your patient is very bradykinetic, double monopolar stimulation using the two best contacts is quite useful at times. And sometimes when that doesn't work, then comes the concept of what is interleaving. Interleaving is where on the same side you set two programs, say using contact 1 and contact 2. They can be both in a monopolar fashion or one in a bipolar, one in a monopolar fashion. You cannot use the same contacts twice in interleaving. So basically you're stimulating two different contacts with two different fields of stimulation, as you can see in this graph. And the net effect is that you'll be stimulating a larger field, but there'll be an overlapping area which will get double the rate of stimulation. And that is why they have fixed the frequency for interleaving at 125, because the maximum frequency allowed is 250. Now, while this may be very good in certain situations, in those where you need high frequency stimulation, interleaving is a straight no-no. So this is an example where we did use interleaving. So this is a farmer which I've treated. I mean, he had Parkinson's since 2003. We had done a DBS in 2010. He did very well. He was very bothered by left upper limb dexterity. Now, the left upper limb was the Parkinson onset side. And while we were able to control it to a great extent, his point was, I'm not able to use the brakes of his two-wheeler. And he was insistent he wanted to drive the two-wheeler. At the Kinetra setting, we were using a fairly high amplitude. And we were using a double monopolar stimulation, 5 minus, 6 minus, in the Medtronic Kinetra system with the standard. This was the standard frequency and pulse width that was available. So when we did change his stimulator in 2014 and moved to the Activa PC, that was the first time where we could do interleaving stimulation. And when we did interleaving stimulation, we were able to lower the current and give him a slightly different range, a bipolar on one side and a monopolar on the other. But what it resulted in, that his upper limb bradykinesia improved to a great extent. He was actually able to drive the two-wheeler in his farm and his village, which he wanted to. But the downside, the IPG drained out in 2 years. We do know that compared to the Kinetra, the Activa PC gives you much less in terms of battery life. And I keep telling my patients, it's like moving from the old Nokia, which gave you long battery life, to the smartphone, which drains your battery with the new features. And that's exactly what the Activa PC has turned out to be. But it did improve quality of life. So in certain situations, interleaving can improve quality of life. And this is more data on interleaving stimulation where certain side effects can be avoided. It can be dyskinesia, it can be dysarthria, but it can help in those cases with interleaving. This is another role of interleaving on situation. And certain situation, however, you must realize that the frequency of interleaving has to be kept below 125. Problem situations include tremor, fascination, postural instability, and the frequency has to be kept only below 125 hertz. The strategies to deal, the next thing from contact stimulation is, many times as the Parkinson worsens despite DBS, we have to deal with axial symptoms. So how do you troubleshoot for axial symptoms? We modify frequency, keep it low if there's freezing of gait, high, as I told you, if there's postural instability or fascination. Many times if there's freezing of gait, you do what is called as a pirouette test, where you make the patient walk in a pirouette fashion like a ballet dancer to understand which leg is the one that is causing the freezing of gait. And you determine that the freezing of gait is more on the right side, then you work on the right side with different situations, interleaving, lowering of pulse width, either which the case, to help try and control that freezing of gait. Lowering the pulse width definitely helps because it improves your threshold and reduces the in the freezing of gait occurring due to stimulation of the pyramidal tracts. And in certain cases, and especially when there's additional dementia, use of cholinesterase inhibitors like donepezil, rivastigmine, or memantine can help in dealing with certain axial symptoms. We may be faced with a situation where there's a sudden loss of benefit or new symptoms. Every time, check the impedance again. And if there is an impedance issue, you have to X-ray the system or look for any break in the situation. And if there is a case, then that needs to be dealt with. Then we come to the newer techniques in DBS, and especially I think what is exciting in what I can see is directional stimulation and current steering to avoid side effects, which has been the biggest bugbear, because you have limited threshold because of pyramidal tract stimulation. And I'm also going to be discussing about the fact that now the choices are much more complicated in terms of which device to implant in a particular patient, and you often have to discuss it with the patient before implanting. The future may hold in terms of adaptive DBS and guided DBS. So this is the concept of directional lead. The conventional lead always gave a circular or fashion of circular field of stimulation, or the VTA, that is the area stimulated. And in the directional leads, you can actually curve the area of stimulation so that you focus only on the area that is required. So this is the multipolar stimulation, and this is the 8-lead directional lead, which is what we are using in the Boston system. So why do we need a directional lead? If you're too anterior, you'll be stimulating the internal capsule, too lateral capsule, too ventral, you'll have other side effects, psychological side effects, too posterior paresthesia, too medial ataxia, diplopia. And that is why you want the current focused into the area which is our target region. And if there is a slightly suboptimal lead placement also, many times we are struggling with the programming, but a directional lead can help steer the current in the right direction. So this is the Boston Scientific directional lead. You have a basic ring electrode at both ends, and the two other electrodes are in a ring fashion with an anterior, posterior, and a lateral lead, and a medial lead. So you actually have this fashion of ring electrode. And what you also have is a marker. This marker corresponds to lead 2 and 5. And this is the marker which will tell you in which direction your ring is, so that you know which area of the brain you're stimulating. So this is the way you stimulate. You basically first program each of these four, you program the ring fully. And then if you find out that the best contact is the lower ring, then you focus that stimulation in the direction that you wanted to based on your anatomical markers. So this is how it would be if you stimulated the entire ring, and this is how it would be if you stimulated only contact to 100%, by where you're focusing the current only in one particular fashion. While here you're stimulating the entire ring. Your contact 2 is at 34%, contact 3 33%, contact 4 33%. So basically you're dividing the current across 3 areas of the ring. While here you're stimulating contact 2 entirely 100%, and you're focusing the current in that particular fashion. So this is a gentleman who has Parkinson's since the age of 33. He's 44 at this point. So you can see he's extremely akinetic. He's in the off state. You can see that he's got a bent neck posture. He's got dystonia of the neck, severe bradykinesia on the left side, masked face, his jaw is open. He has difficulty getting up from the chair. And you can see he's freezing. He can barely lift his leg. And this same gentleman in the on medication stage, and you can see he could hardly take a step here in the off state, and look at his on state. So very good response to levodopa, and we've been priming him for DBS for a long time. So we actually did DBS this November with directional leads. You can see the pull test versus in on versus off, and this is what he is like. So we've actually used contact 2 and 4 in the lower ring on the right side. So we have used the directional lead, and we are focusing most of the stimulation in contact 2, some in contact 4, but we are not using contact 3, which is lateral and is which is going to cause pyramidal side effect. And we are using a reasonable voltage at this point. And this is off medication state. And you can see there's no bradykinesia, it's working well. And this is off medication on stimulation. So this is where we have used a directional lead on one side. On the other side, we couldn't use a directional lead because the best contact was higher up, was dorsal. So you may or may not use a directional lead every time, but it gives you the possibility of trying to in the patient. This is the paper which I found, which they're using what is called as an anodic block. So this is a directional lead, wherein they're using a bipolar stimulation across a directional lead. So they're stimulating. So they tried different settings. The threshold for dysarthria, if you just stimulated one contact, was 2.9. If you stimulated the entire ring, 3.6. If you did just the anterior and just the posterior, 3.9. But if you gave it in a bipolar stimulation, where you blocked the contact, this contact, then you're actually getting, and you're giving 50% in the anterior and 50% posterior, your threshold of stimulation actually improved. So this is bipolar directional steering or an anodic block. So with a directional lead, you have various possibilities to try and improve your outcomes. These are the features currently available across the different systems. This is just to tell you that we have systems. So now with the different systems, you realize that pulse width in some, you can modify frequencies in across the electrodes in some, you can do MICC, which is multiple current control in some. Some are MRI compatible, especially the Abbott and electronic system, which is MRI compatible. You're actually selecting the electrode and you're selecting the system. Now your possibilities are infinite, and you really need to sit and discuss this with your patient to know which system they want to go with. Again, directional leads are available only in Boston and Abbott. So much more complex in terms of selection of which system and in terms of your programming capabilities. And this is what the future might be. This is adaptive DBS, where they look at the alpha, beta, and gamma with, within the electrode records. And when you give medication, the waves you reduce medication according. So so this. Can we mute all the panelists?
Ravi, Ravi, can you mute your microphone, please?
So so basically the adaptive stimulation senses the body requirements and reduces the stimulation when you don't need it. And this is exactly what adaptive stimulation does. This is a study of 8 patients with adaptive stimulation that local field potentials can predict, and 50% less stimulation was delivered during adaptive DBS, which obviously is going to increase the battery life and also reduce the stimulation related side effects. From adaptive DBS, we also move on to the possibility of computer guided DBS programming. So this is using a motion sensor on the index finger. You can use the inputs from the finger of the tremor, rigidity, and bradykinesia, and use that to get a computer algorithm which can determine stimulation settings. And this is the software based stimulation. So this is the the fusion software. So basically there are a lot of softwares that are now coming up that is going to help you guide to decide which are the best contacts to go with, rather than try to go across all the 8 or 16 contacts depending on which electrode you're using, and make life a little easier. So I'll conclude this talk by saying advanced programming can help improve symptom control in patients with DBS. On the contacts front, you can have interleaving, fractionalization of current. I haven't talked too much about fractionalization of current, but you can give a percentage, which I showed in the directional lead. You can give 80% in one contact, 20% in the other. That's fractionalization, which is available on the Versailles and GVA Boston systems. You can interleave stimulation, as I showed you earlier. You can use double monopolar, bipolar. So you can use various contact possibilities. We last time talked about frequency and pulse width modification. Directional need is the new kid on the block. And clearly, I mean, logically, and what we are seeing in practice, it definitely is help improving the therapeutic window. And we don't know what the future in terms of newer advances like adapted and guided DBS is. But when we have so many programming possibilities, yes, you can make the patient's life better. But the amount of time taking to program by the programmer is going to exponentially increase. So we are going to have some computer-based algorithms to help you out, because otherwise we're going to be landing up spending double or triple the time per patient programming, which is not practical in day-to-day life. So thank you very much for your patient hearing.
Thank you, Petrus. I think we will be taking all the questions, and I'll pass on my comments in the end of the second talk. We would move on to the second talk of Dr. Dwarkanath Srinivas. Dr. Dwarkanath is a professor of neurosurgery and head of neurosurgery at Nemans, and he has a great passion for neuromodulation. He's been quite interested in movement disorder neuromodulation and also psychiatric disorders neuromodulation. Let us hear from him about the outcome of deep brain stimulation surgery for movement disorders. Dwarka.
Sorry, can you hear me now? Hello?
Yes.
Yeah, Dwarka, we can hear you.
Yeah, thank you. Yeah. So what I've done is I just speak on the outcomes of deep brain stimulation for various movement disorders, and I'm excluding the psychiatric disorders. It is a huge, vast field, and most of my previous speakers in all the 3 sessions have done a wonderful job in describing the various methods and this one. But what I will do is I'll review the available literature for the outcomes of deep brain stimulation, first in PD and then in dystonia. So as we all know, there have been a few FDA approved indications for tremor, PD, dystonia, and OCD. So I will just concentrate on the first three. The question is whenever we ask about the procedure, we have to ask ourselves, is it beneficial? What are the inclusion exclusion criteria? What are the symptoms to benefit, whether it is the cardinal symptoms or the non-cardinal symptoms? What is the target which you are going to use, age of surgery, long-term effects, secondary effects, and the outcomes and complications. So as we all know that the cardinal manifestations of deep brain stimulation in PD, which are fit for DBS, include rigidity, bradykinesia, tremor, and drug-induced dyskinesias. So I will not go long into the video because many of my previous speakers have shown very good videos. But what I'm going to say is PD does improve all the cardinal manifestations of DBS, improves the cardinal manifestations of PD in most of the conditions. So now if you actually go about and see the origin of literature of outcomes in Parkinson's disease, this was the landmark paper by Benabid et al., who of course developed the deep brain stimulation system. And if you see the effect of bilateral stimulation of subthalamic nucleus on both the off medication and the on medication scores is excellent. And even 5 years after surgery, the effect is maintained overall, as well as speech, posture stability, and gait. While the initial response is good, but what happens is, since PD is a degenerative disease, the effect, the Parkinson's disease itself progresses. But they had very excellent results after 5 years, and the subset scores remain very good. Similarly, this STN effect, the bilateral stimulation, is effective both on the off medication subscores and the on medication subscores. So the question, and this is a meta-analysis by Fissman, who went about and evaluated all the relevant literature on the outcomes of deep brain stimulation in Parkinson's disease. And most of the meta-analysis, you see that the changes in the UPDRS2 scores are around 40 to 60% on average. And the UPDRS3 scores are even further better, and they're around 60 to 70%. The other advantage of an STN DBS is the effective DOPA dose is around, a decrease in this dose is almost around 50 to 60%. Dyskinesia has come down significantly because of this decrease in the LED dosage by almost 70 to 80%. And the other important clinical improvement is the change in the duration of the daily off, which drops by almost 70 to 80%. So it is not that the offs go away completely, but the duration in which the patient stays in his off period is almost decreased by 70 to 80%. The other question which you need to answer is which of the targets are better, whether it's a GPI or STN. And for most part, and this was a randomized study by Weaver et al. On 36-month outcomes on a randomized study of GPI versus STN. What they have said is that in most of the parameters measured, the STN and DBS tend to do almost the same. But there is one small difference in that the cognitive impairment generally tends to be a slightly better outcome in GPI. That has not been replicated in many studies, but that's an important characteristic which we need to remind ourselves, that if a patient has significant cognitive disturbances, it's better to do a GPI DBS rather than STN DBS. I am sure many of my following presenters will be talking about the early STIM. And of course, this was the early STIM study, which was published in Lancet, in which they did primary outcomes on QOL and PD questionnaire, major secondary outcomes and minor secondary outcomes. So what are the outcomes of this study? The most important criteria was, previously we used to use a Parkinson's disease, which is almost 10 to 12 years in duration. The question which arose was it good for even those with disease duration of 4 years or more? The duration of disease less than 4 years were excluded because of fears of atypical Parkinsonisms will not be picked up. So the surgeries and the results were outstanding. In fact, when you compare the neurostimulation with the best medical therapy, even in early Parkinson's in young patients, the UPDRS 3 score, the 2 scores, 4 scores, and all these scores improved significantly compared to the best medical therapy. And this change also significantly remained at 22 years. And another surprising thing was that when they compared the adverse events, there was not a significant difference in the adverse events in the neurostimulation versus the 56 in the medical therapy group. But the one thing which, of course, all of us have to remember is that these adverse events related to surgery or the implanted device is unique to the operated group. And in their study, out of the 26 serious adverse events, all but one resolved completely. And if you see the unscheduled visits which were offered to all health problems, actually it was more in the medical therapy group than in the neurostimulation. And this was a wonderful review of literature by Dr. Doshi on complications of DBS. And if you see the complications of DBS over the years have significantly come down. The most common being is confusion post-operatively, probably because of a little pneumocephalus. But if you see all the other major complications like hemorrhage, vasovagal attack, lead hardware problems, and inaccurate reed placement, is less than 1 to 2% in the most of the recent studies. Infections, of course, 3%, but the incidence has significantly come down from the earlier studies when compared to the present studies. So there is an interesting group of symptoms which are usually not addressed, that is the non-motor symptoms in patients with PD. And this was the outcomes of the early STEAM group. The non-motor system and symptoms are usually not given much importance when you're recommending surgery, but they form a very important part of the outcomes for the patient himself. The early STEM changed the paradigm in which previously all types of behavioral disorders used to be judged as contraindications. But they said that the presence of disabling symptoms which are related to hyperdopaminergic behaviors and non-motor fluctuations, these patients actually improve with surgery and should be considered as arguments in favor of STN stimulation, because the effective dose of dopamine comes down post-operatively significantly and thus improves all their outcomes. We did our own study on NMS in NIMHANS, and we had very interesting findings. Of course, the UPDRS 3 improvement scores was almost comparable to literature, but the LED dose was significantly low, almost by 50 to 60%. And when we did all the various parameters, the Pittsburgh Sleep Index, the sleep latency improved. In the REM sleep behavior, there was a reduction in number of patients who had RBD, but was not significant at 51.8 months, not years. The cognitive, there was no significant change in the Montreal cognitive assessment, but the fluency was one which was mainly affected in patients after DBS. Depression was significantly improved early, but at the end of 4 years, there was no significant change in scores, but anxiety definitely improved both at 6 months and 52 months. The other various NMS scores, there was an improvement at 52 months in perceptual problem, hallucinations, gastrointestinal dysfunction, miscellaneously, which significantly improved the quality of life, which was proven in the QOL, where apart from the social stigma and cognition, the rest of the domains had significant improvement. And another interesting finding was that we found that the impulse control disorders reduced after DBS from 16 to 7. So this is in a nutshell the outcome literature review in PD, and I'll go to dystonia now. And as we all know, dystonia has been classified in 2 main types based on the axis. One is on the clinical characteristics, and the second is on, just give me a minute. Can you hear? Yeah. So the dystonia classification has been divided into basically the axis 1 and axis 2. The axis 1 is based on the clinical characteristics, while the axis 2 is based on the etiology. Etiology, of course, they inherited the acquired and the idiopathic causes, while the clinical symptoms depend upon the extremities involved. So the question is, how do these various forms of dystonia respond? The primary forms of dystonia and the myoclonus dystonia syndrome respond very well, especially the DYT1 positives, the writer's cramp, the spasmodic torticollis. They do quite well with deep brain stimulation. And Andrews et al. In their paper, there was a significant improvement from ranging from around 50 to 70%, but on average around 60 to 65% had significantly improvement in motor severity scores following deep brain stimulation. But these are the primary forms of dystonia. The question is, do the other forms of dystonia, the heredidodegenerative forms of dystonia, improve? There is a particular group of neurodegenerations called the PCANs, where there was a 66% improvement along with dystonia Parkinsonism, which improved significantly. But equally, there are some sorts of heredidodegenerative forms of dystonia which do not respond, like the rapid onset dystonia Parkinsonism. Deep brain stimulation in secondary forms of dystonia has been controversial, and some authors recommend, some authors do not recommend. But in the same review, tardives has shown to have a very good improvement of around 69 to 70%, while the post-anoxic cerebral palsies, post-infectious, do not do very well with deep brain stimulation. So in a nutshell, in primary generalized dystonia, they respond well to palladial DBS. The DYT positive respond better than those who are DYT negative. But independent of the DYT status, PGD performed at an younger age and with lower baseline severity has a higher percentage of improvement of symptoms. Postroventral GPI stimulation has been found to produce the greatest overall effect. Phasic hyperkinetic involuntary movements improve better. Fixed skeletal deformities do not do well because of the deformities, but their quality of life does improve. And the other important thing to remember is that if the patients have cervical myelopathy with myelopathy-induced symptoms, they do not do well as those without cervical myelopathy. Spasmodic torticollis, like I said, do well. Meigs does well. Heredidodegenerative, again, is equivocal. Some conditions do and some don't. And secondary dystonia, apart from tardive, the results are not as good as primary dystonia. But it has been said that patients with a normal brain MRI may do better than those with an abnormal MRI. The other question, and this is our report, this is our series from NIMHANS, and which we showed that in all the parameters of after dystonia surgery, speech, writing, feeding, eating, swallowing, hygiene, dressing, and walking, there was a significant improvement in the scores. And these scores were not only maintained early, but also late. And we have the recent follow-up at 3 years, and the patients have continued to maintain their outcomes. But what about long-term outcomes? That's say 7 years. This was a study which I found by Park et al. If you see that there are 3 clear clusters, one is of tardive, one is of PCANs, and one is of DYTs. The PCANs and the tardives and the DYTs and the tardive generally tend to be more stable, and at the end of 7 years continue to maintain their improvement. But the PCANs, because of the neurodegenerative conditions, tend to actually worsen here. They don't improve as much as the others. In fact, might actually worsen. But it's worthwhile doing in PCANs because the outcomes have been quite good. So this is a case of example of a PGD DYT positive with kyphoscoliosis with severe dystonia. He has a fixed scoliosis deformity. This is a severe primary generalized dystonia, and you can see his gait here. You can see the severe scoliosis. And this scoliosis, you should remember that this is a compensatory scoliosis. So we went ahead and did this. This is the immediate post-op in which the scoliosis did not worsen, but he did send us a image from his house after 6 months, where you see his neck has significantly straightened. And even though the compensatory scoliosis has decreased, he still has a fixed bony deformity, but the quality of life is definitely much better. You can see the kyphosis also has improved from between pre-op and post-op. So this is another patient with tardive, drug-induced tardive dystonia. So you can see the significant cervical dystonia here. And he improved significantly with the deep brain stimulation. And over the years, his BFM scores have come down significantly. And this is him 8 months post-op. You can see the dystonia of the neck has significantly come down. Then there are unique groups of dystonia in which have the separate classifications. One is the dystonic camptocormia, in which there is bending of the trunk. This is a patient whom we did many years back. He's undergone 3 battery changes, and right now is on the rechargeable battery. Finally, you can see the bending of the trunk here. It's almost bends by half. And this is him after almost 5 years after surgery. You can see the trunk has straightened away, and he's done significantly better. This was a paper on dystonic camptocormia. There's another group of tics and Tourette syndrome. I will not go into the details of Tourette syndrome because of the paucity of time. But what I would like to say, the 2 main targets have been identified. One is the centromedian parafascicular ventrooralis nucleus and the anteromedial segment of the globus pallidus. This is different from the postroventral GPI of which is used for dystonia. The target is more anterior and medial in Tourette's. And approximately around 200 cases have been operated. 2 main series, one from Cervello and one from Sachdev, who have demonstrated around 47 to 50% of reduction in tics after deep brain stimulation. This was our patient. You can see his this was the first patient from India, and his tic severity score came down from 96 to 27. And in fact, I'm glad to say that he passed his engineering with the first rank, and now he's looking out for a job in the UK. He keeps on mailing me and asking me whether he can buy a bullet, because that's his dream, to ride a bullet freely. Tremor is another important condition in which the outcomes are very good. And there have been multiple reviews of literature by Pava et al., Limousin, where the improvement is around 75 to 80% in specific parts, the hand tremor, which causes the main disability. So tremor is one of the indications in which the outcomes have been very good. So this is another patient of ours, and tremor actually has multiple targets. Now, if you're going to do an essential tremor, probably we'll use the ventro-intermedius nucleus of the thalamus. So this is a patient with the DBS off. And this is the patient with the DBS on. You can see the tremor has almost disappeared. So this guy was a sari weaver, and he's gone back to his job of weaving saris. But the question is, if you do it for a Parkinson, would you use thalamus, or would you prefer some other target? So the thing is, the subthalamic nucleus itself has very good outcomes in tremor in Parkinson's patient. This is a patient with severe tremor. You can see the poor quality of life. This is a tremor predominant PD. So, and this is his postoperative video. So tremor predominant PD also responds very well to ST and DBS, and in fact, one of the indications in which the surgery can be recommended, even though his other parameters might be quite good, because the quality of life significantly improves after ST and DBS. So I'll just conclude by saying that the outcomes depend upon careful patient selections. Proper surgical placement of the DBS is essential for a good outcome, and you need a multidisciplinary and highly precise setup. There are increasing indications, and a lot of number of cases done today are just a minuscule number of its potential. But what we need to remember is that a deep brain stimulation done correctly in a properly selected patients has very good outcomes. And should be offered whenever you find a eligible patient, and surgery should be recommended. Thank you.
Thanks, Dwarka. We are running short of time. We have one comment or question. Let me throw it to Petrus, and then I'll make a couple of comments on the talks. Petrus, there is a question which is asking GPI versus STN DBS. Can you throw some light on the amount of stimulation required, drug reduction, and also the long-term effect of GPI on dyskinesia?
Yeah. So GPI versus STN, clearly, I mean, there have been head-to-head studies, and many studies have shown that they are relatively equivalent in the short term. I think long-term data is, I think, still what we need. But you must realize that the GPI is a much bigger structure, so the current required is much higher. So you need higher amplitudes, higher. You need multiple contacts to stimulate the GPI. You don't really reduce the drugs as much. There's always the controversial thing whether your psychiatric side effects are less in GPI versus STN. I don't think there's clearly established, and there are a lot of meta-analyses later on which have shown that probably that's not true. So really, I mean, I would say if you're used to a particular target, stick with it. Don't change your target just because there is another target available and you want to explore it. I personally feel that STN still gives you the better bang for the buck in terms of Parkinson's. Smaller target, easier to stimulate, and clearly well established over 25, more than that, about, or we are heading to 30 years of DVS in 2 years from now. So it's a well established target. It's doing very well, and clearly I think I personally, I think we implant almost 90% STN and very little GPI. And the only situations where we have used GPI is where there are already significant cognitive decline set in, and we are doing it as a rescue procedure where the family clearly says we want, there's severe off and that off is horrible and we can't look after the patient, and that's why you're doing it. I mean, there is, so in most situations, I would say STN is better.
Thank you, Petrus. I think I agree
can I
with
just
you.
add a word on that?
Yeah, Dwarka.
That's a good question. The problem with the GPI, like you mentioned, is that the dose of dopamine does not come down. So that is one major disadvantage. But like what Dr. Petrus said, cognitive improvement, decline is not as much. But actually, if you go back into the study which I showed, the initial selection itself for the patient itself was different, because the cognitive index of the patients who were selected for the STN group was less than that of the GPI group. So that was one of the few studies which actually showed a difference. But most of studies have shown no long-term differences between GPI and DBS, GPI and STN DBS.
Fair enough. I think that was a correct and appropriate comment and analysis. Dwarka, your talk was also quite comprehensive. You covered most of the points. One point that I would like to just put it together, as far as dystonia is concerned, it has been shown by Joachim Kraus and his group and his study that younger the patient or earlier the surgery done in dystonia, the better are the results. So you don't wait for too long. And one of the reasons could be, I'm not saying the entire reason is the fixed skeletal deformities that sets in over a period of time. But apart from that, also the outcome is much better. Second comment I want to make is about the PCAN. We have a very good experience of PCAN cases, and it over years of surgery. PCAN itself is a very debilitating disease. And if you analyze this PCAN dystonia, their Berg-Van-Marsden scores run into 90 plus. 120 is the maximum. So 90, 100. So they are very disabled patients. So again, it is more of a palliative kind of surgery than rehabilitating surgery, because overall the lifespan of PCAN is limited because of the disease. And obviously they would continue to deteriorate, but during the period of the life they live, they may benefit from the DBS surgery. And I think we can move on to the next talk, which is going to be much more exciting. And one more comment about directional lead, which Petrus had made before I move on, is that I don't want anybody to get an impression that directional lead is an alternative to a poor surgical technique. The maximum amount of salvage that you can make use of directional lead is around 2 millimeter, which is not a huge amount. So if your target error is more than 1.5 millimeter, even no directional lead is going to help you. So the first important aspect about the surgeon, for the surgeon, it is important is to target the STN very accurately and ensure that you are right there into the STN. Directional lead would help you in getting the finer outcome, the last mile, as you would call it. A person who is very fussy about his speech, a person who is very fussy about that little freezing in his gait. But if he's having severe freezing and you have not been able to succeed there, you are not going to get a directional lead to change it completely, overturn it. So that is one thing that is important, especially because this is a surgical crowd, to get that in knowledge. The next talk is going to be, as I said, is a debate, and the debate we have got very skilled and experienced neurologist and neurosurgeon in the field of DBS from Delhi, Artemis Hospital. Professor Aditya Gupta and Sumit Singh both have been ex-alumni of AIMS, and they have very vast experience of DBS. And what we have selected them to is to debate between themselves as to whether they would go for an early DBS or not. Over to you, Aditya Gupta. The program will be 7 minutes. They will present their case, and 3 minutes they will get a time to do a rebuttal.
Okay, thank you so much, Paresh, for the kind invitation. I'll quickly start sharing my screen. I think 7 minutes, you can really box somebody, you can hug somebody, but to debate with somebody, you really need more than 7 minutes. So I'll start off quickly. So early DBS is the topic of the day for the debate. Now, I think there is absolutely no question about the huge value of neurostimulation, neuromodulation in movement disorder surgery, and we've heard excellent talk by Dwarka to this end just a while ago. Now, as we know, there are several very well conducted studies which have really put to rest that the DBS works, and it works wonderfully. There are several randomized control trials which have been published. So there is really no debate about the value add of DBS per se. Now, it also retains a lot of value after 5 years of STN DBS, and that has been also shown by this very well conducted study in New England Journal of Medicine. So the couple of points I'd like to make is, first of all, I think it's abundantly clear to any of us who treat such patients that the DBS is being done dismally late in not only our country, but many parts of the world. And there is this plethora of articles which attest to this fact of practice. It improves the quality on one hand, that has been very well demonstrated. On the other hand, it's being used very late. That has also been equally well demonstrated. Now, most of the DBS is being offered on the right side of this spectrum, in which there is an advanced life-limiting PD with significant disability. And we just heard about the role of contractures and skeletal deformities. So there is no point in offering DBS at that stage. So patient may no longer be fit enough on one hand and may no longer be active enough on the other hand to enjoy the full benefit of what is a very expensive surgery for some people. Now, there is a significant evidence, and Dwarka has shown several slides on this early STIM study, which has attested to the fact that it has a very clear-cut and remarkable efficacy for these patients if you compare to the best medical treatment. And this is, of course, in the context of a very well-conducted trial, multi-institutional, 251 patients, and with a quality of life detailed evaluation. The results have already been alluded to, and there is a very striking difference if you look at this graph, which tells you not only the basic medical and the UPDRS improvement, which is very drastic and significant, but also the quality of life scores, which actually is what a patient is interested in. Now, there was some comment that there are more depressive episodes in the DBS group, but then in the medical group, you have much more impulse control disorders and motor problems and psychotic manifestations. Now, the conclusions of this early STIM study was very clearly in favor of early DBS, but within very well-established inclusion criteria, which was minimum 4 years after the onset and before 3 years of the onset of dyskinesia. Now, there are several other studies which have also given similar results. I will not quote all these studies, but there are many well-conducted studies which have actually proven that early DBS, but with very clear selection criteria, is a very valuable thing for the patient. Now, one thing which has been talked about and alluded to is that DBS is a very expensive surgery. Now, let's also talk about the cost of medication, which is non-trivial for these patients who are taking multiple medications many times a day. And especially when we talk about DBS being a costly surgery, there have been very clear comparisons. Now, this is a comparison from UK, and it takes into account several European countries as well, in which clearly the DBS reduces the medication cost and enhances the employability of the patient, and therefore the entire socioeconomic impact of Parkinson's disease is much less in patients who undergo a DBS early than in patients who continue to be on those multiple and expensive medications. Now, there is this very exciting concept of a disease modification in Parkinson's disease. So I do not yet have a class 1 evidence for this, but several people, when you look at reports of young onset Parkinson's disease and look at several published papers, most of the people will tell you over a lunch or a conference dinner that in young patients, if you do a DBS in a timely fashion, these patients continue to do well for years and years and years altogether. I think this has been my universal conversation with many of the people who do large numbers of DBS. So that's what I would like to state, that as a clinical phenomena, this fact is probably well known to many of us. Now, there is this, as I said, early DBS may itself have a neuroprotective effect, which is being very actively explored in the current time. I do not yet have a comparison or a prospective or even a retrospective, very robust data to support my claim. But as I said, we are all aware of this as a clinical phenomena. Now, the last point is many people consider DBS to be a risky surgery. Now, you just heard the data which Dwarka showed is from Paresh's review, and this table is from the early STIM study itself. And I'm quoting here another study which was published in 2007, which has more than 1,000 patients. So the mortality risk of 0.4% and a permanent morbidity risk of 1% is really what most of us agree as being a fair estimate of the risk of Parkinson's disease DBS surgery. But the chance of having a hardware malfunction probably is something which is higher. But at the end of the day, that is not something which is dangerous for the patient. So let's be very clear that DBS surgery is definitely not a risky surgery. Now, the DBS procedure has also evolved in the 15 years that you see the data of side effects and morbidity from various studies. We have much more accurate targeting. We are in the process of employing different kinds of atlases for better targeting. We have a better knowledge of somatotopy and use of DTI when we want to plan to reach a particular part of a nucleus, not just the nucleus, but a particular part of the nucleus. And the high quality imaging, which is now there, which did not exist 20 years ago, helps us to avoid even the tiniest of blood vessels in the trajectory. And cumulatively, DBS expertise has definitely evolved in the past 20 years. So what I would say last is that we should be using DBS as a treatment tool, not a rescue tool. And this is basically to use it very, very proactively in selected patients who have the early onset of motor complications at 4 years or beyond after the onset of the disease, and very proactively in certain groups like the young onset Parkinson's disease. So in this diagram, at approximately the 5-year cutoff, when the earliest motor complications start to appear, which is when you want to apply this very valuable technique in order to give this patient the second honeymoon, which I've shown at the bottom of this figure, and which is very, very useful and provides at least 11 to 13 quality of life years added to a patient's life, which I think would definitely justify the cost and the risk of the surgery. So this is one patient which we presented earlier, only 3 years into the disease and intolerant to levodopa. And this is after unilateral DBS. So we get these kind of cases also, which you have to treat keeping aside your early stim criteria. So for this patient, actually DBS was a lifesaver. And another example of a young onset Parkinson disease, which is the group actually I would like to highlight as being being the patients who really should receive this kind of a treatment. And this is a young onset Parkinson disease, 4 years into the disease, dyskinesia for 2 years. So she was started on a heavy dose of Syndopa very early on. And there she is on the day of surgery with the frame on the head. And you can see the typical shuffling of gait, bradykinesia, rigidity. And here you have on the immediate post-operative day. And actually, she did not need almost any medication for a month. And at 3 years, she still continues to require a very, very low strength of current. So with this, I'd like to summarize that I think the DBS efficacy after the onset of early motor fluctuations is well documented. To me personally, neither the cost nor the risk seem to be significant deterrents. Of course, practicing in India, we need to be mindful of the socio-economic limitations. I do not purport to advocate this as a universal treatment, which should be there for all the early DBS patients in the early Parkinson patients in the country. Preferably, these should be done with DBS centers with a significant experience who do at least a case a month. But at the end of the day, it has to be an informed choice for the patient. So this is my last slide. I would say that risks are not zero and there is no clear neuroprotective role, but there is definitely good evidence to support early DBS with very clearly defined selection criteria. But I would still like to offer it as a choice. If a patient wants to wait, they should be able to decide to do so, and the patient should not be pushed into an early DBS. So with these slides, I would like to rest my case in support of an early DBS.
Thank you, Aditya. And let's see what the neurologist's take is that on the early DBS.
So, Dr. Paresh, as usual, you have been an very, very intelligent guy to pin me against a dear friend. And you know that I am a very strong proponent of DBS. So I have very early disclaimers. Aditya is still a dear friend and will remain so. And both of us are very strong proponents of DBS in PD when the patient needs it, whether it be early or late. So when we create indications for a procedure, we have evidence which is published, criteria for the interventions are created, an expert committee creates the selection criteria for a particular procedure, people gain experience to it, and then a decision is made. But we have to agree that we Indians are different, whether we agree or we don't agree. And even for a crisis which was life-threatening like Corona, the cause of Corona, our standards of lockdown, the ways of wearing masks, and the way to alleviate Corona were also very, very different. So Parkinson's disease, which is in itself a very heterogeneous condition, we definitely are going to have problems. So I would definitely be very happy to offer DBS early in Parkinson's disease if it cures the disease, if it controls the symptoms on its own, if it reduces the progression of the disease or is neuroprotective, has a long-term efficacy and safety data backing it, it's cost-effective, and there are strong recommendations of scientific bodies to it. So therefore, there will always be a confusion. What is early, when is early, and how much is early? So if we look at the motor fluctuations, which are probably the basis on which a DBS procedure is initiated, within 4 to 6 years, 41% and more than 9 years, 90% of patients will have motor complications. And within the first 4 years, it would only be 30% of patients who would have these motor complications. And our goal to increase the therapeutic window is not much when the patient is in the early phases of the disease. So our first question, does DBS cure PD? No, it does not. It's a palliative treatment. Is there an overwhelming evidence? Is there an overwhelming evidence for early DBS in PD? And that is where the things started. And this was the early STEM study, which has probably created this issue But here also, if you look, then the mean duration of the disease was 7.5 years, and these patients had a significant amount of motor fluctuations already into their system. So these were actually not early Parkinson's patients. They were relatively earlier as compared to older patients or patients with longer duration of disease, probably at the time when this surgery was being, when this study was being carried out. As expected, it was found that the motor disability was superior in the patients with DBS. The activities of daily living improved. So, and they reported a very, very high incidence of serious adverse events, which I don't agree in the present scenario we observe, as compared to the medical group where the number of complications were less. Now, if we go to a still earlier intervention for DBS, where the patients were less than 2 to 3 years of disease duration and with a relatively lower unified Parkinson's disease rating score, then the results of the midterm analysis of these 24 patients found that none of the criteria, if you look on the right side, met statistical significance. So we knew that patients, if they are operated in the later stage of the disease, have a definite improvement in their clinical status post DBS. So we do expect the type of results which we found in this particular study, which was that the mean UPDRS total and part 3 scores at the end of 24 months of therapy were not very different. Obviously, patients, because they were early in the disease and they were offered a very good proven treatment, which is very effective even in later stages. So these patients obviously were requiring lesser amount of medication. So the conclusion of this study was deep brain stimulation is well tolerated, but it was not able to provide a significant amount of evidence that this is recommended currently. And this was the basis on which a larger study was programmed. And then this is another study which is not even published as yet in paper. This is only e-published, where the 5-year follow-up, 5-year outcomes of patients with early deep brain stimulation was done. And here they again came to the similar conclusion that further investigation is warranted, and the FDA has approved the conduct of a prospective multi-center pivotal clinical trial for DBS in early stage disease. So believe me, this is a single state center blinded observational industry funded study. An extension of a similar study to look at the progression on the rest tremors was also coming out with the similar results. And at best, for early Parkinson's disease, we have a class 2 evidence to support its use. Does it help in the arrest of the progression of the disease? So this is a review article where you can see that close to 1,400 people have been evaluated on which the DBS has been done. And despite the evidence of slowed progression of motor deficits in animal models, when fluorodopa PET scan was done in these patients, then the dopaminergic activity continued to decline in these patients over a period of time. So the neuroprotective effect of DBS was not found in these very large cohort of patients. Now, we all know what are the indications for surgical procedures for PD. Now, what are the contraindications? We have to have a complete possibility of a confirmed diagnosis. We all know that clinicians can go wrong. And usually in the first 3 years, many times there is an overlap between the Parkinson's disease and Parkinson's plus patients. Patients with Parkinson's plus may have a very good response to levodopa, which might be a misguiding reason for us. Dementia is seen in very few patients in the first year of Parkinson's disease, but they might develop in the second year or the third year. So I think overdoing too much in too early stages might not be a right idea. And then let us look at the cost. In India, the cost of medication is not the same as it is seen in countries across the world. We know that the cost of a rechargeable implant, which would be required mostly in a patient with early PD, would cost about 14 lakhs. And this is what I have formulated as a calculation of the full treatment of Parkinson's patients for 5 years. Levodopa would cost about 18,000 rupees for its 5-year treatment. Pramipexole, 82,000 rupees, and Rasagiline for 24,000 rupees. And this is a cost effect analysis which has been done, in which 14,980 documents were screened. And it was found in this condition, in this particular review, that the optimal medical treatment was cheaper as compared to deep brain stimulation, especially in patients with early Parkinson's disease. And of course, there is no cost efficacy analysis from India, as far as I know. Is it absolutely safe? There is no doubt that it is definitely not as safe as optimized medical treatment, and definitely not in very early or early Parkinson's disease. I think this is an overestimate of the adverse events. Dr. Paresh, Dr. Aditya, and Dr. Dwarka all know that the type of side effects which have been reported globally probably are not too true, and the side effects which we have observed in our patients are much less. But still, it is definitely not 100% safe. And of course, the neuropsychological observations are the ones which are of significance, particularly in early Parkinson's patients. And people have found word fluency and frontal lobar dysfunction in patients who have undergone deep brain stimulation, particularly in the first 12 months. So are we ready? So we are offering the treatment of a patient which is not curative, neither neuroprotective. It's not cheap or cost effective in a country where medical insurance percolation is less than 30%. It's not free from side effects. It's not backed by evidence which is better than a class 2 evidence at a time when we might be actually wrong in our diagnosis. So my question is why? So the world might be ready for an early deep brain stimulation. We are definitely not. But it is not that I would not offer it for patients with early PD. We would try an optimal dose modification. But if a patient has disabling motor fluctuations, an earlier surgery may be indicated if there is a risk of job loss, loss of independent living, and the inability of an individual to perform his or her functions in the family and the society. Thank you very much for your kind attention, and here is where I list my case.
Thank you, Sumit. It seems like in the end, both of you are coming closer to a central point wherein both have kind of toned down the part that yes, there is a role to be played and there is a selective role to be played. If I call it from Sumit's side, it says that it is a role to be played. And from Aditya's side, if I say that he would use it, that there is a selective role to be placed. So do you guys want to go for rebuttal or we can go for some discussion, whichever way you want to say?
See, debates, whenever we speak, are always polarized, but the reality always lies in between.
In between.
So I don't think that I am ready for requiring a rebuttal, because we both know that if required, whether it is early or
You will
late,
go
we
for it.
will offer
Exactly.
brain stimulation.
So that is why I said the concluding slides were kind of meeting the endpoints both. So which, what do you say, Aditya? You would like to say anything?
I mean, I agree. So only one or 2 points I would like to say. I think Sumit would also agree that if we follow broadly the early STIM study criteria, we may actually advise DBS to most of the patients who have those criteria fulfilled. And from my side, I would absolutely not be in favor of doing a DBS within first 2 or 3 years of disease. The question does not arise in choosing such a patient, because we have been working together for 20 years and the protocol that we follow is already in both our frontal lobes. That is almost set in stone. So impossible to change that. Now, the other
We
comment
debated only for the purpose of debating in this particular
Exactly.
event.
No, so that is what I wanted.
and the other thing is,
But you negotiated your way out, actually.
so the only other thing I would mention is that for a patient to whom the cost is not a barrier, so when you talk about the economics, so Sumit showed very nice data that what is the cost of Syndopa and pramipexole treatment, and DBS, of course, in India is much more expensive. I would say for a patient who can afford the freedom from the on and off phase that these patients do have, for a patient who can afford, would be worth many times the inconvenience and the cost that a affording patient would be ready to give. That is my feeling when you see the effect of DBS in these well selected patients.
Exactly. So I would like to just stress two important points out of this debate, which are very important. I want to re-emphasize. One is what Sumit pointed out is that the biggest risk of offering early DBS is missing the diagnosis, and that is an error rate up to 30%. So one of the best way for the people who do not want to fall into that trap is to keep a 5-year line. So beyond 5 years, you decide to operate, you would be relatively safe. I think Aditya also pointed that out in his talk, that this is a very important pitfall that you may have, because these are the patients, they will come to you because they are not so happy with the Parkinson's disease medication, and you apply the criteria and you see that the criteria are fitting it, and you may be tempted to offer, but these are the actual patients that you want to avoid. So you require a fantastic level of experience, and that is what Aditya pointed out, that not less than 100 dbs. So I would strongly suggest and recommend that don't attempt dbs in less than 5 years if you have not crossed the mark of threshold of 100 cases, and if you do not have a strong movement disorder specialist by your side, because the early dbs patient is something that you do not want to put your hands in, because it is very tempting. Patient is asking, patient has got funds, patient is ready to do it, and you are willing, and that is where the trap will come. So I think that the purpose of bringing this debate was actually to highlight these aspects of where this trap will be and how to avoid that trap. Milind, you want to make any comment?
Yeah, yeah. Hi, Sumit. Hi, Aditya. So, one of the thought processes which was going in as Sumit was presenting was this very thing. Like people who have not really, done many DBSs or who do not have a very strong movement disorder neurologist, particularly when someone is really taking it on, there is a point to be proven to the society or for that matter to yourself at many a times. And that is one thing which one should really avoid rather than, take your time, let it be so that you're doing it a little late, it doesn't matter. But I'm sure the patient will have more faith in you rather than, trying to do an early DBS and realizing that it was a wrong indication. So I think it was a very good debate from that point of view.
Thank you. I think we can move on to the next presentation, and that is going to be by me. Unless you have any closing comments, Sumit or Aditya?
No, I would just like to say we have reaffirmed our friendship at the end of this debate.
That's what I said. That's why I took away the rebuttal. So I said there is nothing to rebut. Shake hands and move forward. You can have a glass of wine or whiskey, whatever is your choice. Yeah, I know Sumit's choice, so I don't know so much of your choice though. Okay, so I'm going to move on to the next talk, which is going to be by me, and I'm going to talk on the hardware complications, surgical complications after DBS. Let me just start with sharing the screen. Give me a minute. I need to, yeah. Just give me a minute. I'm not able to find this window though. So. Oh, yes. Okay. The slides are seen correctly?
Yeah, go ahead, Paresh.
Thanks. Yeah. Okay. So we will rush into this complications of deep brain stimulation surgery. I've divided the complications into 3 different areas. And basically, the surgical complications, hardware complications, and stimulation related complication. Now, surgical complications can be divided into various aspects. One is intraoperative. This can be pneumocephalus, vasovagal syncope attack, aspiration, breathing difficulty, and intracerebral hemorrhage. All four have occurred in our practice, and it will occur in your practice as well as you progress to do more and more surgeries. And the post-operative complications that I want to highlight about here is confusion. So last time also in the previous webinar, there was a discussion as to how we can avoid pneumocephalus. And one of the ways of avoiding pneumocephalus that we have seen in our practice is that initially we used to open the dura, and you can see that there is a large amount of pneumocephalus here present, whereas now we do not open the dura. Like you can see here that we are piercing the dura with the help of a microelectrode tube, and we are being able to avoid the complications of pneumocephalus. You may ask a question that how do you avoid any hemorrhage from the cortical small vessels, and that is by careful surgical planning. The second thing that we are very careful about is vasovagal syncopal attack. There are some of the centers, especially in Western countries. I don't know many centers in India doing that, but in Western countries, they fix the frame in either the ward or in the CT scan department. We like to avoid that because we always fix the stereotactic frame in the neurosurgical OT. These patients of Parkinson's disease, we find them very anxious. Though we spend 2 days of time to prepare them for surgery, even then, when they come into the OR, they are very anxious. And that could be the particular reason why that pain that you give, even if you have given anesthesia, and if there is any significant amount of pain that the patient perceives, he may go into syncopal attack. And we did find that in our series as well. So to avoid that, we have an anesthetic monitoring, we establish an IV line and then move forward to fix the frame. The third important aspect is about the aspiration. The head position, especially the neck flexion, is very important because when you are using a stereotactic frame, you are using several levels of clamping behind the frame. And this limits the amount of extension that you can give comfortably to the patient. At the same time, you want to have a little sit-up position, and all that is going to add to the discomfort of the patient. So we are very particular in making sure that the patient's head is slightly extended and he is able to swallow his saliva. This is a test that we do. We ask him to swallow the saliva. So in case there is accumulation of saliva during the surgery, which there will be, he is able to swallow comfortably and he doesn't develop aspiration. Also, we use this kind of stereotactic frame, which has an intubation facility in the front. So you can remove this clamp in the front and you can access the airway comfortably in case there is a difficulty of airway and breathing. Post-operative, immediate post-operative complication is something that we are concerned about. We recently evaluated this in our published paper. We found that it was around 6% in our series. It was found only in the Parkinson's disease patients. We had evaluated all the deep brain stimulation surgeries. We have been performing deep brain stimulation for more than 15 or 10 to 16 indications. So out of that, we only found that confusion was only seen in patients of Parkinson's disease. It extended from 1 to 5 days. In one patient, it went beyond a week also. Minimal to marked confusion, more common in GPI DBS. Contrary to our belief, we had been discussing since morning whether GPI is safer than the STN, but we also had that impression. But when we analyzed our data, we found that the confusion was much more common in GPI DBS, and I will tell you why. It came out through the multivariate analysis that we conducted. The multivariate analysis, which analyzed the age, sex, duration of disease, microelectrode recording trajectory, target, and MMSE, all were analyzed. The only thing that came out positive or which to the value which contribute to the confusion was target and MMSE. More than 25 had an influence. So if you had a more than 25 MMSE, you are less prone to confusion. If you have less than 25, you can be more prone to confusion. And that is the reason, as Petras told you, that we usually use GPI stimulation in patients with cognitive decline. And the GPI stimulation, you can see that there was more confusion because these patients were already cognitively challenged, which has been reflected as in the multivariate analysis. The second dreaded complication is intracerebral hemorrhage. We all had our share of intracerebral hemorrhage. We have had 7 instances of intracerebral hemorrhage out of 520 cases. 2 were asymptomatic. 2 patients, we had to abandon the procedure. 3 out of 7 developed permanent deficit. including one with a valve. One patient had a cardiac valve in whom we had to start anticoagulation after 5 days. He was normal till 5 days. On the 6th day, when we had to start the anticoagulation, he immediately bled. And this is still considered as an operative complication, and hence we have included in it, though technically it is not a surgical complication. Again, we did a multivariate analysis to find out what are the causative or predictive factors for this hemorrhage. Age, sex, microelectrode recording trajectory, and targets were analyzed. We found that microelectrode recording trajectories of more than 2 increases your risk of having hemorrhage. Last 200 plus surgeries, there has not been any incidence of hemorrhage, and I will tell you why I'm putting that statement. We will talk about it as we progress further. We now move on to the second part of the complications, and that is the hardware complications. We had 35 cases out of 751. How 751? We had 519 primary implants, DBS, bilateral or unilateral, and IPG replacement in 232 cases. There was erosion and infection in 2.95% of cases, 3% cases, inaccurate lead placement, lead fracture, IPG malfunction, hardware discomfort were all less than 1%, which is a very acceptable rate. Now I want to spend a little more time on erosion and infection, because that was, if you see that was the largest number of hardware related complication in our series. This is a recent patient whom we performed deep brain stimulation in 2020. We all know that in March, the lockdowns were effective. So he called us up and sent us a picture saying that, sir, there is some swelling over the IPG site. We all will agree. We asked him to do CVC, CRP, everything was normal. And we asked for this picture, which showed nothing there. No color. It looked a little swollen, but we thought that it could be just the IPG, which is looking more prominent. 3 months down the line, on 5th June, he sent us this picture saying that, sir, you missed it and there was an infection or there was some inflammation we did not see. But if you see it again carefully, there is no sign of any inflammation here. So we immediately agreed that, yes, this looks like infection. We started him on antibiotics to see if that would help him. Again, the lockdowns were there and things were not fully functional. However, by 30th June, we had a breakdown in his neck wound and there was some pus discharge. So we went on and explanted the IPG and disconnected it at the neck as well. This is the site that you can see that we removed it at the neck, and there was some inflammation at the neck wound also. We cut the extension wires at this slightly pulled the extension wire and cut it. So extension wire must be lying at the tip would be lying here. Unfortunately, we expected to heal, but in 1 month's time, initially it healed, but it again broke down. So there was some pus discharge, and there was this looked a little swollen, but there was no collection. So we decided now we will have to disconnect the extension wire and leave the leads inside. So we left the lead inside and removed the extension wire, hoping that it will settle down. Unfortunately, very soon, in 20 days' time, he came back to us saying that, sir, there is a little collection here. We did not find a collection. It was looking a little swollen there, but we had not found any collection. But we were now concerned because it looks like that the infection is not coming under control, and we went for a full. This is what we are showing you, that there was no. There's no collection. It was just a swollen connector site, but he did not want to take chance, and we did not want to risk now having seen the previous experience. So we had to explant his electrodes. So we tried our best to salvage. It's not that we have not been able to, we have been able to salvage some of the implants, but sometimes we have to go for a complete explantation. Now we will go on to the stimulation-based side effects. This is the third part of the complications that I would like to talk about. And very early in 2002, we reported and we found that some of the patients were unusually depressed after stimulation. And these are not the patients who actually were depressed. And we knew that after DBS, the depression usually improves. So we tried to extrapolate and see this. And what we found that one patient had developed a depression over a time, and in 2 patients, it was acute. This had only occurred after we changed the stimulation setting. So we really correlated with one of the reasons postulated by the physicians and the neurologist was that reduction in the dopaminergic drug following STN stimulation can bring out the depression. But we discussed internally and with the neurologist, and we could come to no conclusion because we had not reduced so much of the drugs. And it was related to stimulation, because when we changed the stimulation parameter in these two patients, the depression improved. So we reported this, and since then we now know that around 4% of the patients after DBS can have depression, though 80% of them improve. What are the thought processes as to what could have caused this depression? Current spread to the adjacent structure, we now know that STN is not only the motor nucleus. Global stimulation of motor and limbic STN, and abrupt withdrawal or reduction in dopaminergic drug, that you should always consider first when the patient comes for reporting depression. But in our case, we had not that as the cause. Another stimulation related side effect that we found, and which was reported in 2008, was hypersexuality following subthalamic nucleus stimulation. Again, here we had 4 patients who were elderly, beyond 60 years, and were not very sexually active because of their advanced Parkinson disease, became highly demanding and sexually active, watching pornography, reading books, insisting on sex with their spouses, and this was very abnormal. It took some time for us to get this history out of the spouses, especially there were a couple of patients of them were coming from very conservative family, and the spouses were not very happy to discuss this openly. But we could find it out because we have a very experienced Parkinson disease nurse specialist. She's a female nurse, and she has been working with us for last 17, 18 years. So patients open up a little bit more, and that is another take-home point that you should have, that you may have to have a female person within your team, which would help you to assist to understand these patients much better, because there are certain things about patients. I'm not talking about hypersexuality only, but there are many things about the patients which they will open up to a nurse or to a female assistant, which they may not open up directly as a consultant to you. So despite good control of Parkinson's disease, we found that they had symptoms of hypersexuality, and we know that STN stimulation is usually known to improve DDS. We saw the impulse control behavior. Dr. Dwarkanath showed in outcome that from 11 patients that he had suffering, the 7 patients only suffered after STN DBS. So you can have an improvement, but sometimes you can have complications also, and that could be related to increased availability of either dopamine because of the stimulation or because of the limbic component of STN being stimulated. Now, Petra showed you the improvement with a directional lead. I would show you how an aggressive behavior, we also reported aggressive behavior in our article that we published. And this is a patient with a directional lead who had become very aggressive on a routine programming. The directional lead helped us. He has become very aggressive, not listening to anybody. Now we are going to move on to stimulate the directional lead. These were the initial settings, right and left. Modified settings now. Going to activate the directional lead. And you can see that the current is steered. We have blocked the part of the current by not giving current to one of the contact points. Here we used all the 3 contact points. He has completely tamed down. This is the next day. Comfortably chatting with the doctor. So he says only 5% of the symptoms have been left. So this is the beauty of having a better programming capabilities and understanding that stimulation related side effects do occur, and you have to know your way to work around them. Now, this paper that we published had a very important aspect also to highlight, and that was the learning curve, because this is for the first time it has been established that what would be the threshold of a learning curve beyond which you can say confidently that the number of surgical complications will significantly improve. So this was one of the things. If you see here that our hemorrhage complications kept on reducing 4 from initial 0 to 100 cases to 2, then 1, And last more than 200 cases now, we did not have a single hemorrhage. We had published 2 papers on this. We have published a paper earlier with 150 surgeries. So we have our data of that paper. And now in 2021, we have now published this paper on experience of 519 cases. And though the total number of complications have reasonably remained same, the curve and the learning curve has shown that the number of complications occurred more in the early part than the later part. You can see that as the years of experience increases, that number of complications continue to regress. And again, a statistical analysis showed that 200 cases is the something that of cutoff which we can have. These are the overall results outcome that we compared with the international series with experience of more than 150 cases. Because as I told you that if we compare with the series of less than 150 cases, the results will look very good. But we had to compare with apple to apple. And then when we compared to larger series, the outcomes and complication rates were very comparable. So to conclude, I would like that DBS is not sticking an electrode in the brain. It is different from the routine neurosurgery as you are involved in changing the life of a patient permanently. It has to be practiced with utmost caution, reverence, and patience. The more you do, the more you would improve. Take support from a center who has got a good experience. This may help to improve your learning curve. With that, I would end. Thank you. I think we will be taking all the questions in the end. You can put it in the chat box, and we would go to the next lecture by Dr. Milind Sankhe, who is going to, he is a consultant neurosurgeon and very interested in DBS and has been practicing almost for 20 years now. You would talk to us about do's and don'ts or all the precautions that you need to take after DBS. Milind.
Can you see my slide?
Yes, yes.
Okay. So, good evening, everybody. And I'm going to talk in terms of what exactly after DBS, and there are a lot of misconceptions about certain things as to you cannot do this, you cannot do that. So I'm going to try and cover it in very simple form, something like healing and recovery, which is probably something which has been emphasized upon by Paresh as well when he discussed about the wound healing and gave a very nice example of the same. Some amount of activity restrictions which are needed in the early part of recovery from the DBS, certain environmental considerations which include use of certain electromagnetic devices, and what medical procedures can be done, particular references to the MRI scans. So healing of the wound is not something which necessarily happens and it is over with, particularly given that this is an implant which goes all the way down into the brain. One needs to be careful, and was absolutely aptly demonstrated by Paresh just now. So appropriately, that patient raised an alarm with the kind of swelling that he had and the pain, and it was unfortunate that the patient went on to develop this sort of a issue that the implant had to be removed and had to be explanted. Certain activities, I'll show you an example at the end as to what can happen after 5 years as well, after a well-settled implant, if you have excessive muscular activity. So certain activity restrictions which are in the immediate particular phase are, severe high impact activities can really lead and to the wound dehiscence itself. Other aspects you need to be aware about is avoid scuba diving in the immediate past, and definitely do not venture into diving below 10 meters if you're looking at someone who is really interested and has that sort of desire. Uh, uh, Environmental considerations and particular references to electromagnetic interface, which is something which is in a day-to-day routine and involved in our healthcare industry as well. So quite a few of these actually do interfere with the implanted system, and that is true for whether it's a cardiac pacemaker or, for that matter, a brain pacemaker. And these sort of receiver devices are very commonly seen nowadays in our world, and one needs to be aware that these do actually cause issues with the devices from time to time, and one needs to be aware about the same. Simple things like simple things like, going through screening devices as well will actually, at times, though not on a routine, it will definitely raise an alarm, but at times can actually change the settings. What is safe from interferences? Things like a computer, cell phone, or routine household appliances are generally safe. Whereas things like theft detectors, security gates, large high voltage power lines, or major communication equipment, particularly those who are actually in the service industry for the same, they would be having some interferences and a possibility of the same. Some red flags, particularly the use of diathermy, is something which one needs to be really aware about. So exposure to monopolar diathermy is completely avoided and to be forbidden. Sure enough, you can do the procedure with a bipolar diathermy, and we'll emphasize a bit more on this. Exposure to MRI and things which we'll discuss it in a little more in detail, but an MRI is something which is now not contraindicated, and if you're using a 1.5 Tesla MRI machine, it is fine. It's not a big issue. We'll discuss that nevertheless. Use of antipsychotic drugs. Now, unfortunately, quite a few of these patients are seen by psychiatrists as well, given the fact that some of them essentially have depression, or some of them have severe hallucinations. Some of these hallucinations are drug induced, some of these hallucinations are stimulation induced. And I like to try and highlight by giving an example of one particular case of how use of antipsychotic drugs can cause a reversal of the symptoms or reversal of the benefits. Use of, sorry, I'll just transcutaneous TMS versus DBS. We'll discuss that as well. So some of the medical procedures, there are certain misunderstandings about certain procedures, and there are common questions which are put are these. Like, do you really have to avoid an X-ray? No, you don't need to avoid an X-ray. You can go ahead and do an X-ray any given time. That's not a problem. Can you do a diagnostic ultrasound? Sure enough, you can do a diagnostic ultrasound. You just need to be aware that there can be a mechanical interference. The same is the case with an ECG machine as well. Simple things like, can I do a dental procedure? This is a fairly common question. Sure enough, you can do a dental procedure, but if you're planning to use certain electrical drill equipment, you may turn the IPG off, but it can be very, very difficult. You don't need to necessarily turn the IPG off. Can you use a TENS machine for pain control? Well, you can, as long as the does not really pass the pain, the TENS unit current does not necessarily pass through the neurostimulation system. As far as lithotripsy is concerned as well, because this is one other question which is quite regularly asked, you need to be aware that this has to be slightly away, the beam has to be slightly away, which is not much, less than half a foot. Should you or should you not do a CT scan after a DBS? You can do a CT scan and there is no need to turn the implant off. Sometimes it may happen that it can be because of the direct beam, there may be some sort of a feeling that a patient may experience. In such a situation, one may simply just check the settings, but generally a CT scan is not a problem. Use of a diathermy, as I said earlier, one needs to understand the difference between a direct current and an alternate current. By itself, the direct current is not a problem, but an alternating current will pass through the body and can have some ramifications through the system, through the DBS system. One important part is that if you actually use a diathermy very close to the implanting system, you may actually damage the insulation which is there in and all through the extension wires. Now, one of the major problems is that if you're actually having a neck surgery following this, and if you're going to use a diathermy, which is contraindicated, but there is a direct chance of an insulation damage as well, and one has to be very, very careful, particularly if you're really undertaking a neck surgery. And this insulation damage can happen not only due to a diathermy, but can be due to a direct blade as well. So preferably use, or rather use only a bipolar diathermy. If you have to use, then it has to be only for procedures which are far away, extremely low power setting, and do not use full length operating room table grounding pads. Every time you use it, please check the neurostimulator settings, including make sure about not just your standard amplitude, pulse width, or for that matter frequency. Please check the impedance each time. I'm not going to dwell much onto this. So coming to the MRI scan, there's a common misconception that one cannot do an MRI scan at all, but there are certain guidelines which are provided, and generally it is better that an MRI scan is done at least under the guidance, if not under a direct supervision of the treating physician. So a 1.5 Tesla machine is okay. And if you can limit the SAR absorption or the specific absorption ratio to less than 0.1 watt per kg, it is particularly for the head coil, it should be okay to do an MRI scan as well. And this is something which we've been practicing for many, many years. I have been for the last 20 years, I don't remember not doing an MRI scan for any of these patients. And all patients of mine undergo an MRI scan between stage 1 and stage 2. As far as full body MRI machine MRI is concerned, that is also possible. It is not an issue, but make sure that the machine is checked, with impedance is checked, and after the impedance is checked as well, you need to ensure that you turn the machine off, and once the MRI scan is over, you reset the and turn it on and make sure that the settings are properly maintained. So verify, make sure that prior to the scan, you check that there are no open circuits. That's essentially done by checking the impedance. These are certain guidelines which have been given. Essentially, there is no contraindication, but preferably turn the machine off, turning the therapy off, turn the machine off, check all your settings and go back onto the same settings. MRI is possible, but do it under guidance or under supervision. So one such example, which Paresh had mentioned, this is someone who was operated 5 years ago, 2016, early 16 is when he was operated upon, a young guy, and he fits into the early stim because he was operated at the I think 5.5 years or 6 years after his PD was diagnosed. And young guy, he's now 38, if I'm not wrong, and is very keen on exercises. And you can see that he slowly, over a period of time, his implant has eroded through the skin, and the scar at the of the IPG insertion site is quite well, but the implant has actually eroded on the lateral aspect through the skin. And this is something which he quite conveniently ignored for roughly around 3 to 4 weeks. And I think he did send a picture to our neurologist, to my neurologist, but she didn't really think that it was, that time it wasn't serious. Unfortunately, it kept getting worse. And one of his close family members noticed this, and he posted this picture. He had to be called in. And obviously, just as Paresh did, we had to salvage the implant. The implant has been removed, and the wound has been sutured, and this is roughly around 10 days down the line. There is a small pocket which has been created very close to it, and I'm trying to save the connecting devices and the cables as well, and I'm hoping that this is now almost about 2.5 weeks plus, and we are hoping that this is not going to be a problem as far as the extension of infection is concerned. Hopefully, we will be able to preserve it and give him back his same implant. Coming about use of antipsychotic drugs, this is a lady who is in her mid 50s or late 50s. She's been diagnosed with PD for about 11 years, a tremor dominant PD with dopa-induced dyskinesias. She underwent an ST and DBS about 7 months ago. she unfortunately had disturbing hallucinations, and which really became a problem. So the neurology and the psychiatry team got together, and they started him on mirtazapine, but no benefit. Started her on mirtazapine, but no benefits. Uh, she went on, the medications were changed, and she was put on clozapine. And you need to take my word for it that about 3 weeks down the line, she was initially started on a very small dose, just at about 25 milligrams once a day, and slowly put up every week to about 3 tablets. And by the time she was on 75, and within about a month as such, after starting the medication, all her Parkinsonian symptoms returned. All the benefits disappeared. With the machine on and with the medications, she would get no benefit at all. So just about, literally about 3 weeks ago, we stopped her clozapine completely. All her Parkinsonian symptoms have disappeared at the end of 10 days. She's now completely off clozapine, and she's back onto her back onto her well, she's actually doing very well now with all her benefits restored. So avoid antipsychotics, and rather than doing anything, just simply try and stick to basic drugs, and stick to what your neurologist tells you. Having said that, I don't want to disappoint anybody that these complications are after many years, and one gets excellent results, and some of these are results which have been over a number of years. Like this gentleman was operated about 16 years ago, and he still continues to have the great result. You can see this lady which you're seeing just now, she's been operated. She's the first case that we have done, and she remains. This is our first case, that is in March 26, 2001, and she remains till date doing very well with her symptoms, just not showing any signs. And she is now into her fourth battery, and now she's into the RC. This is an example of how patients do well with primary dystonia, and the young girl is the DY-T1, whereas the gentleman below is DY-T6. Both of them have been doing extremely well. Unfortunately, the gentleman below died a year ago, due to a year and a half ago, due to non-Parkinsonian reasons. And it is not just Parkinson's or for that matter dystonia. These are two examples of tardive. One is the lady above is a tardive dystonia, and the gentleman below is tardive dyskinesias. You can see that these are patients who've been operated now 9 years ago. One of the lady above has been operated almost 12 years ago, and they've been doing extremely well. And these are all with DBS. And just to finish, movement disorders is not only about DBS, and this is just to emphasize that movement disorder surgery is much more progressive and much more wider when you're thinking in terms of doing lesioning. Doesn't have to be expensive. One can do lesioning surgery as well. And one such example over here is a post-cavernoma excision, severe hemiplegismus, which this young girl has developed. And now this is post-lesioning. And this effect has been, this surgery is almost about 2 years ago. So to conclude, and the take-home message at the end of this movement disorder program webinar would be that all movement disorders program across the country should be encouraged. Sure enough, you should be proctored for the same, because knowledge of the same is to be gained slowly, and proctorship is necessary in the beginning. And finally, it's a team job. Thank you for your attention.
Thanks, Milind. We can take some questions, or we can have a discussion amongst ourselves. I think there are a couple of questions which were there. which we can take up.
So I'll I'll read out the questions if you want.
Yeah, please, Milind, go ahead.
Um, one of the questions that was asked is, what are the additional investigations required for rapidly progressive symptoms of PD, and how to rule out how to rule off dopa responsive non-PD in early disease? So I suppose this was a question which was aimed at trying to figure out. Maybe Sumit can answer that question. Sumit, the question is essentially how to find out whether this is a dopa responsive non-PD in an early disease.
Yeah, so see, the point is the very soft signs need to be seen, like in patients with progressive supranuclear palsy, a very slow or a change in the speed of eye movements, looking at the axial rigidity more than the appendicular rigidity, sometimes looking for an applause sign. So these are indicators that it is most likely a PSP which is evolving over a period of time rather than a Parkinson's disease. Then looking for autonomic dysfunction in patients with multisystem atrophy, which is usually missed. We usually might not see evidences for soft autonomic dysfunctions like erectile dysfunction, which can be seen in early PD as well. Significant fluctuations in the blood pressure, postural hypertension. So these are the things which usually should be looked very actively if you are having doubts in a patient who has Parkinson's plus, which is responding to levodopa rather than Parkinson's disease.
So yeah, so true to, as you were mentioning earlier as well regarding when you were debating that wait for some time, do not be in a hurry, and definitely not before 3 to 4 years to be not do secondary PD as such. So there's one more question, which what would be your criteria for early DBS against CAPSIT PD criteria? This is by Dr. Rajesh. He seems quite active.
Basically, CAPSIT PD criteria need to be re-evaluated, and there are certain papers which have come up where CAPSIT PD criteria need to be revisited. Actually, that is the title of those papers. So I don't think that CAPSIT. Aditya, you're there. You can answer this question.
Yeah. So, well, I think Sumit knows more about CAPSIT criteria. What I basically understand is that CAPSIT criteria were floated in the late 90s, and mostly in whatever conferences and meetings I have attended, and you see these criteria are really not being followed any longer. And as Sumit said, there are a lot of papers which say that we need to move out of these very rigidly defined criteria. In fact, the CAPSIT criteria was so rigidly defined that they've quantified the percentage of relief after a levodopa challenge. Then before so many months, before you plan the surgery, the patient should have a daily diary of on phase, off phase. It's a very, very restrictive kind of approach. In
Yes.
fact, one paper which I read said that if you go strictly by CAPSIT criteria, of all the PD patient, only 1.6% will qualify for DBS.
Yes, exactly.
So I think we are moving out of the CAPSIT criteria, and we are more or less, I would say, I would personally like to mirror the criteria which was set forth in the early STEM study, because that is the
Yes.
only almost kind of a class 1 evidence which we have. And I think I would just like to follow exactly the early STEM criteria, of course with some exceptions. Like we showed you a patient who was completely intolerant to levodopa. We had no choice but to do a DBS in the first 3 years of disease for her.
And that second patient who was started very early on very high doses of levodopa,
Yeah,
who developed
absolutely.
dopa associated motor fluctuations very early in her course. And she was
Yes.
almost debilitated because of dopa produced dyskinesias and dystonias. So I agree with Aditya completely. The captured criteria are almost given up right now. We
Dwarka,
go
you want to
mostly by our
add?
clinical acumen and personal experience over a period of time.
Yeah, Dwarka, you want to make a comment?
No, it's fine. I think I agree.
I think we had a very good, lively discussions over the 3 webinars, and all the faculties delivered their best and shared their personal experience, and that was what was important to bring out in this. And I'm sure that this will stimulate a lot of people to think about starting this program and take support wherever they need. And I once
Few
again
announce-
thank the ISSFN. Yeah, you want to say anything, Milind?
Yeah, I have a few announcements to make.
Yeah, so just after I conclude, if you can make the announcement, yeah.
Yeah.
So I would like to thank the ISSFN for giving us this opportunity, me, Dwarkanath, and Sandeep Aishya to moderate these 3 sessions and conduct these webinars. And now I hand over to Milind for housekeeping announcements. Yeah.
Yeah, so the moderators for these 3 webinars was Paresh, Ravi Gopal Verma, and Sandeep. So I'll just do that correction, not
Sorry.
Dwarka, but
Yeah. Thank you. Yes.
we are all a part of the same team. Yeah. So it's really been very good attendance. And if I could just make some announcements regarding the number of attendees who've actually attended these. In the webinar 1 for MD, we've had 430 attendees. In webinar 2, we've had 260 attendees. In webinar 3, we've got 274 attendees. Now, my appeal to most of the attendees is that please look at functional neurosurgery, movement disorder neurosurgery, or whichever is your choice of interest. Please look at it and look at it favorably. Do take up these programs. You will need a proctor, so be it, but do take up these programs. Second announcement is that ISSFN is very keen on encouraging young programs, young onset programs. So please join ISSFN, do become participants in the ISSFN activities, take up memberships, please contribute to the society by more participation. We will be more than happy. I would actually like to add that a lot of these participants, essentially you would be able to see these talks on the ISSFN website. Please visit the website. The initial webinars which included stereotaxia and epilepsy are already uploaded, and the MD webinars, that is movement disorder webinars, would also be uploaded in this next 10 days. So please do that. Finally, we are taking a break on next Thursday, but we are back in a fortnight from now. That is the Thursday. That would be, today it is the 10th. So we are talking about the 24th. We are covering another very interesting and extensive topic, which is unfortunately not given due attention in the rest of the general neurosurgery or the glamorous neurosurgery that we talk about, including pain, radiosurgery, and spasticity. So please join us on the 24th of June, 1st of July, and on the 8th of July. So with that, with permission from the moderator for the day, if everyone is okay with it, we could conclude the session.
Thank you. Yes, we can.
Thank you.
Thanks, everybody.
Thank you.
Thank you.
Thank you.